Hi, everyone. This is Shoshana Zatz from the California Institute for Mental Health. Welcome to the first Small County Fiscal TA webinar. In a few minutes, Mike Geiss is going to be getting on and taking you through some of the financial issues facing small county mental health and behavioral health agencies at this time. But first, I need to tell you that you're all currently muted, but Mike will be pausing on a regular basis to ask for questions. So if you want to ask a question, you can do so by either typing your question into the question box or by clicking the hand icon next to your name, and that will alert us to take you off mute so you can ask your question. You should all have received the materials for today's webinar via email, either yesterday or today, but if you don't have them, send me an email or type your request into the question box. My email is svatz@cimh.org. One last thing, this webinar is being recorded and it will be posted probably no later than Monday. So as soon as it's available, we will send out the link and you will be able to view it or send it on to colleagues who weren't able to attend today. So thank you very much, and now here's Mike.
Good afternoon. So what we're going to cover today is what was discussed at the September 5th CMHDA Financial Services Committee meeting. So a couple weeks ago, and you can see the list of items there on slide 1. So jumping right in with the new billing feasibility system study, hopefully as most of you know that CMHDA is funding a feasibility system study for a new Medi-Cal, especially mental health reimbursement system. This has often been referred to as short DOIL 3, but I think it's going to probably be more of a reimbursement sort of approach than purely just a system. There was a policy paper that has been developed, which looks like this, and hopefully you've received that and maybe taken a look at that. But that is really what the feasibility study will take a look at. And in terms of really where I think CMHDA wants to go is to more of a CPE-based or certified public expenditure-based claims process, rather than focusing on making sure that claims are approved and adjudicated at the state. It is going to be more expenditure-based, where the amount of certified public expenditures is determined locally. They still have to be Medi-Cal services that are provided to Medi-Cal clients in a Medi-Cal certified setting, but it really focuses more on how you're doing your cost finding in determining the certified public expenditures versus whether you can get a claim that is approvable and adjudicatable through the state. And again, cost finding is typically more based on OMB Circular 87, Medicare Principles of Reimbursement, rather than having the focus on this whole claims process. And if you look at the policy paper, you'll see where it does talk about rather than having the state adjudicate claims. Again, this would be something that would be determined locally, where the counties would basically adjudicate their own claims, similar to a managed care entity. You still would have to be submitting data up to the state, probably encounter-based sort of data, similar to the managed care plans, but it would be significantly different than the process that we deal with now. In terms of where this is in process, Cal MHSA, the Joint Powers Authority, has been retained to manage the process. And again, since CMHDA, the counties are funding this, Cal Mesa has developed a schedule of the amount that each county is basically been invoiced for, and I'm not. Well, apparently it's based on your MHSA allocations is how they determined each county's share. And so we talked a little bit about, apparently Cal Mesa has sent out invoices already, and the amount shown on that invoice does reflect what each county would owe if every county participates. And so we had a little bit of a discussion about whether counties should try to at least get authority for a higher amount in case there are some counties that don't participate or decide not to participate. And Cal Mesa, Sarah, who was there, said she would work with counties if they have any questions. So you definitely would want to contact her. Cal Mesa will also, I assume, assist with the procurement in identifying the vendor and actually the whole process. And there are two separate committees that have been discussed at this point, and I believe the governance committee has been established. And in fact, I believe their first meeting is October 8th. And then as well, there will be a steering committee that will include representatives from the CMHDA committees as well as DHCS. And the CMHDA committees that were discussed were Financial Services, the Information Technology Committee, and then the Medi-Cal Policy Committee. It sounds like this is going to be, it's a fairly formalized process in terms of doing an FSR, feasibility study report for the state. And I think in terms of just timing that it probably isn't something that's going to be complete this fiscal year in terms of the actual feasibility study and selection. So it would hopefully be done, within the next year or so that we will have a new system in place probably in fiscal year 15-16. So definitely something to look forward to that will hopefully be easier and won't be, so dependent on minutes of service, getting adjudicated at the state, service function codes, all that sort of stuff would hopefully go away as part of this, and we would end up in more of a expenditure-based sort of approach. So that's the new billing feasibility system study. Anybody have any questions here on this? Okay, moving on to the Short Dole 2 update. We talked a little bit about the other healthcare coverage denials that are continuing. And these are for the Medicare risk HMO claims. And really the biggest issue here, I think, is just how the state is going to handle these aged out claims to where the policy folks are consistent in informing of the auditors so that that you can get credit for these aged out claims that are continuing to be denied. We talked about production testing, and again, live test is allowed through November 1st of this year. After that, we're going to have a new test environment. And I know this has really been more focused on the IT committee, but it sounded like you were supposed to let DHCS know the live SIN numbers, but also that DHCS will be issuing, hopefully, an information notice on this so that you have additional clarification on how to handle testing after the end of October. We talked a little bit about DSM-5. Again, DHCS is working on an information notice that would provide some guidance. It doesn't sound like there will be an immediate switch to the DSM-5, so we'll still be using DSM-4. And there is some concern that there would actually have to be some regulatory changes in order to implement DSM-5, which the regulatory process is a little bit slow, so it's not something that's going to happen overnight. Does anybody have any questions on any of those issues? Okay. We talked a little bit about KDA and implementation of KDA. Yeah.
There is a question from Kimberly Danner. It says, is the SDMC system able to accept OHCS claims now?
My understanding is that they're getting denied. And so my understanding again is that they really haven't changed the process and that those claims are getting denied. All right. So moving on to the KDA implementation, DHCS indicated that they posted a draft report, although I looked all over their website and could not find anything in terms of actual data being posted. They did issue an information notice on some of their data collection efforts, but I didn't see an actual draft report. There are specific service function code to identify the KDA services, and we talked a little bit about whether each provider that is providing KDA services needed to obtain the certification for those specific service function codes. And at that meeting, the state was not sure. And again, where this is coming from is when the auditors come out and they look to see if a provider is certified for a given service, we wouldn't want those services to be denied. And so the state representatives, DHCS representatives at the meeting were not sure, but they were going to check and get back to us. So, and even getting back to us verbally, I think we still would want something in writing because, you know, when you get audited 5 years from now, 6 years from now, you're going to want some official documentation to support what you were doing. So hopefully that will come out soon as well. Then we talked a little bit about the county contract rates. In this, these are the rates that you claim for your contract providers. And DHCS is concerned that there may be some data entry errors that would result in a significant overpayment, and so they want to catch those up front. So they want to put a systems edit in place to identify these prior to adjudicating and paying the claim. What they suggested at the meeting was to use an amount equal to twice the highest county interim rate as the edit they would put into their system. And then they suggested that they would adjudicate at that rate for any claim that exceeded that edit rate or that maximum rate. What the counties then suggested is rather than adjudicating that claim, that the state just put a hold on the claim or suspend the claim and discuss with the county whether that was the appropriate rate or not, rather than adjudicating it at a completely different rate that the county probably wouldn't be able to reconcile. So hopefully we'll hear back at the next meeting as to whether the state was willing to do that. I think it does meet their goal of not paying a claim you know, that significantly exceeded some sort of common sense check. But then at the same time makes it a little bit easier for you guys to continue to reconcile things versus paying at some rate that you would not even be aware of. The other thing that was interesting is that this has never occurred, so that there never has been an instance where there apparently was a data entry error resulting in a significant overpayment. As most of you know, your rates are based on tables that you typically would have in your system, and it would have to be that table that would be incorrect. So it's not a matter of you know, an individual claim line being entered incorrectly. It would be a matter of the rates in the tables being input incorrectly. So again, more to come on that, and hopefully DHCS will go with the county's recommendation to basically hold these claims if it ever does occur versus adjudicating them at a different rate. So anybody have any questions on that stuff? All right. Moving on to the MHSA update. So as you're probably aware, DHCS conducted a survey a couple months ago around unspent MHSA funds from the fiscal year 09-10 distributions, so monies from 09-10 that had not been spent. We didn't really get into it too much other than to find out that the results of this they've been posted and they're on CMHDA Financial Services Committee website, but it basically is the OAC who will be taking up this issue through their finance committee, and so that's where that is at this point, and we'll see what comes out of that. In terms of the allocation percentages for fiscal year 13-14 of MHSA funds, DHCS issued information notice 13-15, and you can refer to that and see what percent of the MHSA distributions that each county gets and that your county gets. Those are the same percentages that were used for fiscal year 12-13, so they did not change. We didn't really talk about it, but just more as a FYI, the Oversight and Accountability Commission did publish guidance on the 3-year program and expenditure plan, and that would be for fiscal year 14-15 through 16-17. If you go to the website that's listed there, at the bottom of the page, it has the some information and the guidance on that, as well as the budget forms to use. I know we had tried to get somebody from the OAC at the meeting last time, but hopefully in the near future they will come and discuss what their expectations are of the budget figures or the fiscal pages. And then DHCS also announced that they released Information Notice 13-17, which is the MHSA 11-12 Revenue and Expenditure Report. The report itself is, well, at the component level, it's not that different than in prior years. It's a little bit more detailed in that they're asking for every program to be identified separately, and then they are asking for different funding sources for the overall program expenditures. But what's really different is the unspent funds page, and then all the reversion calculations. And in fact, they announced at that meeting that there was a problem with the way the innovation reversion was being calculated, and then they supposedly fixed it and reposted in the forms themselves. The only thing I can say on this is that the reversion, and CMHDA continues to say this, that the reversion needs to be done through the regulatory process, that they shouldn't try to implement their interpretation of statute through an information notice. And I'll talk a little bit about that more later, but I think the other main thing is that if you have questions or comments on this form, I would direct them to Donna, and you can see her phone number and her email address. I think the more that you can let her know the complexity of doing some of this stuff and the lack of clarity, I guess, on some of this, the better off I think we all are, because I think that the state doesn't believe this is that difficult, and it's not that big of a deal in terms of their reversion policies. So anyway, I would suggest contacting the state, and you've got the contact information there. And then finally, they did indicate that they are in the process of developing an information notice on their reversion policies. Again, that isn't really consistent with state law that says if you're going to interpret statute, you need to do it through the regulatory process. So we'll see what that looks like when it comes out, and we'll go from there. Anybody have any questions on any of those items? All right. We also talked briefly about the Bureau of State Audit's MHSA, and it was called an audit, but it's basically an MHSA report. There's the link to the report right there if you want to take a look at it. CMHDA is working with the OAC to address some of the recommendations made by the Bureau of State Audits in the report. Some of the things that will probably come out or have come out of that are that you will be getting a performance contract hopefully pretty soon, and that the Medi-Cal triennial reviews will include some MHSA pieces to it, so that they will start to look at that a little bit more. At the meeting, it was discussed that the October CMHDA All Directors meeting would have a panel on outcome measures, because that was really what the report stated was, and actually I thought it was fairly critical of the state more so than the counties, but it said that nobody knows what is being received for this huge amount of money. What are people's lives being improved, and what is really going on with this money, and basically a lack of oversight from the state in terms of trying to look at that and look at some of the outcomes. There were no specific financial findings, but again, this was more of a performance audit than a fiscal audit, and so it was more looking at performance associated with the act versus going in and auditing transactional level expenditures. So, anybody have any questions on the MHSA report? All right. Then we talked about, got into the claims payment update. We talked a little bit about the 910 cost report settlement. And now all the missing 835 files have been released, so that counties should be able to do their 910 cost report settlement. At the time of the meeting, there were still 15 counties that had not received their 910 cost settlement letters. I was actually in one of those counties earlier this week, and I know they have subsequently received their cost settlement letter and have 30 days to prepare their cost settlement. You definitely want to make sure you're including these approved Medi-Cal units on your 910 cost report reconciliation so that you get credit for it. And then it was brought up by one county that some of these claims are too old to verify against the med system, so the med system doesn't go back far enough to allow you to check eligibility. And it was unclear, I think, what counties are supposed to do with that. So hopefully more to come on that. And actually, I think even some of the claims were older than 910. They might have even been 8-9 claims. We talked a little bit about the 8-9 cost report settlement, and DHCS had sent out invoices, gosh, I want to say back in June or so, and then they have begun doing the offset process or the green sheet process. They indicated that they are aware that counties cannot reconcile these offset amounts against the invoices, and then it apparently MedCC could also not provide the supporting documents for the offset amount. So the state's still working on trying to develop that process and clean up that process, because ultimately you need to be able to reconcile this stuff in order to keep track of your funding. So hopefully, again, more to come on that. So anybody have any questions on any of that? All right. We moved into a little bit of an explanation in terms of why, for example, you received all these different invoices, and DHCS kind of went through the process a little bit, and it really comes down to how CMS is requiring the state to report their expenditures of the claims or the reimbursement amount, the FFP, on the quarterly CMS 64 report. And those are by different programs, which would be looking at just regular Medi-Cal. You've got the MCHIP program, you've got the BCCTP program, there's the pregnancy program, and then there's Healthy Families. And those all have to be reported separately. In addition, what also is reported separately are medical services, which are basically direct services, versus administration, utilization review, or Medi-Cal administrative activities. So that is why the state is invoicing you in this fashion. It's basically a CMS requirement. So unfortunately, it makes it very complicated and difficult to reconcile. And we talked a little bit about the reconciliation of the managed care offsets. The state's been promising a report for a couple of years now, and they are still promising that report that would allow you to reconcile the managed care offsets against the TARS that you're approving for the fee-for-service Medi-Cal inpatient services. It sounds like that's at least a couple months away still. So again, we'll keep it on the agenda. We'll keep discussing it, and hopefully at some point we'll be able to reconcile the managed care offsets. One thing that was brought up to me recently was that the 1213 offsets, if you looked at them in aggregate, seemed to be pretty high relative to other years. And when you look at the dates on the remittance advice in terms of when the offsets occurred, it looks like they actually shortened the amount of the offsets for 11-12. So in other words, they didn't have a full fiscal year in 11-12, but then they made up for that by having 14 months in 12-13. So it just shows the need for these reports so that you can reconcile the amounts that are being offset, and so that you can have some sense that they are in fact accurate. And then we talked a little bit about the MHP contracts. As of the meeting, there were only 7 counties that had not returned signed MHP contracts. DHCS indicated they are not holding up claims pending the approval or pending the submittal of a signed contract, but they may revisit that in the future if they don't get these 7 counties to submit their signed MHP contracts. All right, anybody have any questions on this or anything to add? All right, we talked a little bit about the, actually it's basically just a state budget update, really focused on the behavioral health sub-account, and there are 2 parts to that. One is the sub-account growth, which the state had anticipated. I believe there would be about $14 million of growth in the behavioral health sub-account associated with sales tax collections in 12-13. You know, again, the behavioral health sub-account includes quite a few programs. It includes the EPSDT program, which includes the transition to healthy families in KDA, as well as it includes the Medi-Cal, especially mental health managed care allocation, as well as all the substance use disorder services. So it includes quite a bit for that 12 to 14 million, which is around 1 to 2% of the base for 12-13. And by the way, the base for fiscal year 12-13 was met with the July payment, which is why you did not receive an August distribution in your behavioral health sub-account, is because the rest of 12-13 will come as some sort of growth distribution. So DHCS has received the principles from the relevant associations, CADPAC, CMHDA, and CSAC, regarding how the growth should be allocated, and they're working with the Department of Finance, the Health and Human Services Agency at the state, to try to get together with the stakeholders who also want to provide input into how this growth is distributed. So we'll see how long that process takes. Hopefully not too long, because typically the reconciliation is done by about now or maybe the end of this month. And so hopefully you would get that growth typically in October. So hopefully that's on a fast track and can get distributed fairly soon. CMHDA recommendation has already been distributed or had been made. You can see that's this here. And this is really, it's the growth distribution. Actually, it's even beyond 1213, where it talks about 1314 should be considered the base. And then look at annual growth distribution, looking at the following factors, which included beneficiary population, penetration, utilization, and costs, but not look at those on a year-to-year basis, but over a longer period, maybe a 3-year period. And there was also the drug Medi-Cal minimum base of $100,000. So these were the principles that CMHDA, CADPAC, and CSAC put together and gave to the state. So we'll see how that factors into ultimately how some of this growth is distributed. And then the 1314 behavioral health subaccount, as of the meeting, DHCS had provided the schedule to DOF. Hopefully, and we just received that today. So that was emailed out this morning to hopefully all you folks, as well as the directors. So you should take a look at that, and that would be the percent of revenues into the behavioral health subaccount that you would receive in 1314. And your first distribution for 1314 should be coming up here a week from today, I believe, so that you would actually see that percentage applied against whatever the revenues are. And then I believe DHCS will also be coming out with an information notice in terms of how they came up with those percentages, similar to what they did in 1213. And so hopefully at the next Financial Services Committee meeting, we'll have that information notice and we can review it and discuss it and ask any questions of the state at that point. So anybody have any questions on the growth or the 1314 for the behavioral health subaccount? Okay. Then we went into the work group updates for a little bit. So the first one dealt with the fiscal state plan amendment, which from our perspective, the main importance of this is that this would allow you to claim or submit a supplemental claim from January 1st, 2009 through the end of 11/12 for any certified public expenditures that you incurred in excess of the SMAs. And it sounds like DHS is still working on this, but that they were getting pretty close and that they anticipated releasing the claim forms so that you could see what they look like in a couple of weeks. So hopefully, again, that will come out soon. And what we're hoping that this will look like, because we really haven't had any chance to, nobody's asked, DHCS has not asked us to review anything, but hopefully it's just a simple one-page form that piggybacks off your cost report for the given fiscal year that you can voluntarily submit and certify that you incurred certified public expenditures above the SMAs, and that hopefully you'll get FFP based on that one-page claim form. And then I would imagine you'd have to do a separate one for each fiscal year, and that hopefully this would be part of the typical cost report reconciliation process. But again, more to come on that, and hopefully we'll see something by the next Financial Services Committee meeting. The other thing that DHCS has in process is the CPE protocol that they submitted to CMS, and apparently they've received some additional comments, and that DHCS is responding to those and intends to resubmit by the end of September. So that is still in process. And then hopefully you're aware that the cost report template, or at least the detailed cost report template, and the instructions for fiscal year 12-13 Medi-Cal, especially mental health cost report, has been posted. They haven't posted the summary cost report template yet. I think they're working on how to look at some of the settlement issues around the UPL, the upper payment limit, and CPE. The other thing I want to point out, and hopefully you're aware of this, is that there's been quite a few iterations of the detailed cost report template. In fact, I believe they just posted a different version this week. So make sure when you do this that you use the most recent version, and you might even want to hold off a little bit before populating the cost report to make sure that they actually have the final version all already in good, so that you don't have to do data entry a couple times. And that was it for the work group updates. Anybody have anything?
There is a question from Kimberly again.
Okay.
Will they be providing a cost report training?
So the state, my understanding, the state already did a cost report training, which from what I heard was typical of what they've previously done, which is just basically walk you through how to use the program versus providing any sort of guidance on content. So what CIMH is going to do is we're actually going to do a training for just the small counties. And Shoshana, I don't know if anything's gone out on this to the small counties. I know the directors are aware, and we're going to try to do that the afternoon before the CIMH Fiscal Institute, so that Monday afternoon. And I want to say
November 4th.
November 4th. So just for small counties, we're going to have something on November 4th. So put that down on your calendar, and because the issues you guys deal with are so different than what a lot of the larger county issues are, we just felt it would be much more beneficial to just focus on you folks, and so we'll be doing that in November. As far as the state, I believe they are done with doing any additional training on the cost report at this time.
And there's a question about the recording of this webinar. You'll be able to see, I will send you the link to the recording probably by Monday, and it will also be posted on our website. So just look for an email from me Monday or Tuesday. Okay, go ahead, Mike.
Yeah. So after this, we get into county-to-county stuff. So we talked a little bit about the Affordable Care Act implementation, or the expansion implementation, and just what's going on there. So CMHDA, just to give you guys an update, was going to be meeting with the health plans, because really one of the big issues is trying to distinguish what is specialty mental health versus psychiatry and psychology that the health plan should have to cover. And from that basically the level of functional impairment of the client should be the basis for making that determination. Ultimately, that would get into any sort of MOUs between the health plan and the mental health plans. And really, it should be a two-way street in terms of referrals, where you're accepting referrals from the health plan, as well as you should have the ability to refer clients that aren't at the level of functional impairment for specialty mental health, you should be able to refer those clients to the health plan. So there's a bunch of issues, coordination of care issues. We talked a little bit about how you could have an instance where you've got a short-term inpatient psych stay that really after that the client should go back and be part of the health plan for the outpatient treatment and the follow-up treatment. CMS is obviously concerned about any sort of double billing or double payment. So again, a lot more to come on this. And in fact, you probably received a survey this morning, or I believe it was this morning, from CMHDA asking you what your rates are that you pay your fee-for-service Medi-Cal providers, your psychiatrists, psychologists. And so DHCS is trying to get a sense of how that really works. We talked a little bit about the drug Medi-Cal SMAs, and what we have now is because of the expanded benefit of drug Medi-Cal under the Affordable Care Act, there is state general fund involved. And so we anticipate that the 13-14 SMAs will stay the same as prior years because of the state general fund. And there's a whole host of issues going on with drug Medi-Cal that will hopefully be worked out, or at least clarified in the next couple of months. Then we had a pretty lengthy discussion on the behavioral health sub-account, and really the issue was there's been some counties that found out the data that they submitted as part of the 11-12 EPSDT distributions. They discovered that data underreported their true certified public expenditures, and so they wanted to update their 11-12 amounts, especially to have it updated as part of the behavioral health sub-account. And so we had a pretty lengthy discussion on that. And I don't think we're totally finalized on that, but again, the state did come out with the 13-14 distribution schedule, but they also did, if you look at the letter that went along with that, say that they reserve the right to adjust those should additional information come out that that would warrant them to revise that. I think from a budgeting perspective for the behavioral health sub-account, that you're going to want to look at the percentages that just came out and apply that against the total amount that was distributed for 12-13, because there is such little growth, or maybe increase it, the 12-13 amount by say 14 million and apply those percentages, and that's probably going to be your base for 13-14. The downside to that is that most counties, well, overall, we're only anticipating 1 to 2% growth in the account, and depending on how your percentage is shaked out of that distribution schedule, I saw some counties with a pretty significant decrease in their 13-14 funding over what they received in 12-13, such as in the neighborhood of 10%. But even if your percentage was the same, you only would have been looking at a 1 to 2%. This base level of funding is not sufficient to fully fund EPSDT for 13-14 in any county. The state had estimated somewhere, I believe, around a 7 or 8% growth increase in EPSDT services, just doing their normal claims forecast, and there isn't that much growth from 12-13 to increase the base. So it's going to be interesting to see how counties deal with EPSDT in 13-14, because really you need the 13-14 growth, which won't be known until October of 2014 to really fund any sort of increase in EPSDT services, and in some cases even to be able to fund your EPSDT services at the level you did in 12-13. So I would imagine we'll talk a little bit more about this at the next Financial Services Committee meeting, especially if DHCS has issued the growth amounts from 1213 at that point. We talked a little bit about the MAW audit issues. Fresno is now pursuing legal action and trying to get counties to participate in that. And I believe Alameda is participating in Orange. So you've got some of the larger counties that are going to participate in legal action against some of the way that the auditors are interpreting the way that the MAW program. So, and this has to do primarily with how the MAW percentages are determined, and where the state is saying you've got to use the percent of your overall county population that's Medi-Cal versus the amount of the population that you actually serve or that you're even responsible for that are Medi-Cal, which would be a different way to look at it. So I'm assuming, again, we'll hear more from Fresno, because I think they were starting to run out of time on in terms of filing some legal action. And then finally, we talked a little bit about the revenue and expenditure report. Again, for the state to issue the revenue and expenditure report with reversion as an automatic calculation without any dialogue or without any regulatory authority is not really what, well, it's not consistent with state law in two areas. Just general government code requires the state to interpret and make specific any sort of statutes through the regulatory process. And even beyond that, the MHSA itself specifies that DHCS and the OAC are supposed to implement the Act through the regulatory process and make sure that that regulatory process allows for the most input, public input as possible. And so obviously that wasn't met with their interpretation of reversion. And the main issues on the reversion are whether counties have the ability to put PEI funds in a prudent reserve. And so that's one of the issues. The other issue, which is probably more pertinent to all of you, is how the state is interpreting the treatment of interest earned on the fund and of Medi-Cal FFP received as a result of an expenditure of the fund. And so they're basically saying that they're going to look at how you funded services and in terms of reversion versus whether you incurred an actual expenditure of MHSA funds. So they're looking at more the net MHSA versus the gross MHSA, which again, the Act doesn't necessarily say that. And so, at this point, I don't think it would be CMHDA or CMH's recommendation, but I don't know if I would complete the unspent funds page and ask my auditor controller to certify that everything in that report is correct if it in fact was showing that funds would revert, because that means that you're certifying that yes, you have funds that should revert. And until the policy is put forth in regulation and gone through the public process, I don't think I would ask my auditor controller to certify to that extent. So anyway, and I know, I don't even know if the formulas are correct. I don't know if anybody's completed the form, but I think it's somewhat difficult at this point to say to go ahead and do that, get your auditor controller to certify it, and say that you have funds reverting. The one thing, though, I would suggest you do is try to complete the component pages so you're at least reporting expenditures to the state. And really where that's coming from probably is a little bit to do with the audit that the Bureau of State Audits did. And you don't want to look like you're completely not wanting to report anything up to the state. But so I would suggest you at least report the expenditure side. But to go through and try to do that unspent funds page and figure out the reverted funds and then certify to that, I think at this point is not necessarily the best way to go. And so that was it. And it, yeah, so that was it in terms of the Financial Services Committee meeting. Anybody have any questions or want to add anything?
There's a question. Has there been any more talk regarding MHSA audits for other counties, especially small counties?
I'm not aware of anything. So, you know, I don't know. I don't know where the state's going to go with this Bureau of State Audit report, because the issue wasn't that funds were being spent improperly or you know, inconsistent with the plan. It was more basically that the state just had no idea what the funds were being spent on, and what sort of outcomes were the result of this additional funding. I would imagine, you know, well, in CMHDA's position, and this is why you have this auditor controller certification, is that it is a local process. And so you've got your auditor controller certifying that that these were the expenditures, they were appropriate, they were consistent with the act, and that should be sufficient. But at the same time, given this report, who knows politically what will result of the report, and whether the state will audit the MHSA expenditures as well. But they will audit it from a Medi-Cal perspective, because but that's just your normal Medi-Cal audit. But in terms of auditing the specific MHSA, I haven't heard anything. But that doesn't mean that there won't be.
There have been a couple of questions about the small county cost reporting training on November 4th. Someone wanted to know where it was going to be held, and it will be here at the CIMH office in Sacramento. And the time will be, I believe we said 1 to 5. Is that right, Mike?
Yeah, and you know, if we need that long, and what are we in? We're in September, so I mean, definitely. In fact, we might even, well, we're definitely going to want questions from you folks beforehand. And so if you've got some issues you want addressed, and we want to keep it a little bit more informal than maybe some of the other trainings have been, so that we can really get into some of this stuff, and so that you can get the answers that you want. So yeah, and we also tried to piggyback it on the back of the, like I said, the CIMH Fiscal Institute, which is that Tuesday and Wednesday, and then there's Financial Services Committee on Thursday. So it would basically mean you'd be probably out of your county for most of that week, but we thought that would be easier. Shoshana, are we going to have any sort of webinar capabilities on that?
I don't know the answer to that yet. We might be able to do a go-to meeting kind of thing.
Yeah.
I'll see what we can do.
But again, the thought was, if you're coming to that Fiscal Institute, you know, you can come down the afternoon before, and we can go through cost report stuff specific to small counties, rather than, I know that larger meeting tends to be, it is definitely not addressed just to small counties, as well as there won't be probably any discussion of cost reports at the level you would want in the Fiscal Institute meeting. But any other questions?
There is another question. Do you have any sense of how long until the state resolves the unspent funds issue, gross versus net method? Will counties refusing to submit that have negative repercussions?
So a couple of things. CMHDA continues to maintain that this needs to be done through the regulatory process. What probably has to happen at some point is, either once once the state, assuming that they do issue an info notice on reversion policy, somebody needs to file a petition with the Office of Administrative Law saying that it's an underground regulation and therefore is not enforceable. And so once that happens, I think all bets are off in terms of the revenue and expenditure report. How soon that will happen, I don't know. The other part, though, is that there are no, the statute says that you're required to submit a revenue and expenditure report to the state. It doesn't say necessarily it has to be complete, you know, and it doesn't say that the state has any repercussions or ability to withhold funds or anything like that should you not submit. You know, unfortunately, we didn't have that much time to talk about this at the last financial services, and I know this next one is a joint IT financial services meeting, so we might not have time at this one either. But basically, the state has there should be no repercussions should you choose to either submit it incomplete. And again, the main reason I'm saying submit it incomplete is because of this other audit, because I don't want it to look like, I don't think we want it to look like counties are you know, not complying or not wanting to show what they're spending. So that's why I'm saying even submit a partial one. But the state has no authority. The state has no authority to withhold funds. The other question that's come up is, you know, how are they going to actually, should you show a reverted amount and say you agree with that amount and you want to certify it, how is the state going to collect that? And again, we have no idea. We don't believe the state can do offsets because I don't think that's consistent with the Act. They would need to implement a regulation in order to do that. They should actually have you cut a check, which also keeps it cleaner from your end so you know which year it's being reverted from. The other part of this actually that I didn't mention was in looking at the net and in factoring in Medi-Cal, should you have a disallowance at audit or at reconciliation that causes a reduction in that Medi-Cal, therefore increasing your MHSA expenditure, and if you had reverted funds and turned them back to the state, I don't think there's a way to get those funds back. So that's what I'm saying. It's unfortunate that the state went ahead and felt they needed to do this, and as a result, it's almost kind of a wait and see because there's just so many problems with it. So hopefully we'll hear more at the next Financial Services Committee or shortly thereafter. But I think it's going to take a while to resolve. All right, any other questions? All right, if not, then that's it. It's 2 o'clock, so thanks for joining, and we'll see you hopefully in a couple weeks at the next Financial Services Committee meeting. Bye-bye.
Just to let you all know, the next Fiscal TA webinar is scheduled for October 18th, 1 to 2. Thank you all for joining us. We'll talk to you next time.